We are going to discuss the most important salicylate member, acetyl salicylic acid, or simply aspirin, as a prototype of NSAIDs. This presentation is prepared by Professor Mohammed Abdelbari, Professor of Pharmacology, and Shams Faculty of Medicine. The narration was read by Microsoft David Voice. First, the pharmacokinetics. Absorption. Distribution. Elimination. Second, the pharmacodynamics. The mechanism of action. And the pharmacological actions. Finally, the pharmacotherapeutics. The indications. And the various adverse effects. The aspirin trap means accumulation of aspirin molecules in the gastric cells. The pKa constant for aspirin equals 3.5. This means that, if aspirin is dissolved in a solution, whose pH equals 3.5, 50% of the molecules will remain as such, and the other 50% will be ionized, to release the negatively charged salicylate ions, and the positively charged hydrogen ions. If the pH of the solution is less than 3.5, ionization will decrease, and most of the aspirin molecules will remain as such. On the other hand, if the pH of the solution is greater than 3.5, most of the aspirin molecules will get ionized. In the gastric lumen, which contains hydrochloric acid, the pH is very low, about 1.5. Accordingly, most of the ingested aspirin dose will be in the non-ionized form. Since the non-ionized form is lipid-soluble, the aspirin molecules will cross the gastric mucosa. And they will enter inside the gastric cells, where the pH is 6.5. Since this pH is much higher than the pKa of aspirin, most of the molecules will get ionized. The few, non-ionized lipid-soluble molecules will cross the gastric mucosa. And the remaining ionized molecules will be trapped inside the gastric cells. The non-ionized molecule, which cross the gastric mucosa, will enter the blood, where the pH is about 7.3. Thus in the blood, the absorbed aspirin will get ionized. Aspirin is commonly used with warfarin, both in prophylaxis and treatment of thromboembolic diseases. However, aspirin interacts with warfarin, at both pharmacokinetic and pharmacodynamic levels. At pharmacokinetic level, aspirin affects binding of warfarin to plasma protein. This is the molecule of albumin, the most famous plasma protein. Albumin is made of amino acids. Some of these amino acids are acidic, some are basic, and some are neutral. The basic amino acids are capable of binding acidic drugs, so they are called acidic binding sites. Warfarin is one of the famous acidic drugs, that is 99.9% bound to albumin. This means that only 0.1% of the warfarin dose is free in the blood, and this very small fraction is the active part of the dose, while the albumin-bound part is inactive. When we give warfarin, we adjusted the dose, so that there are enough free molecules to achieve thrombolysis. We measure the thrombolytic state by a test called INR. Aspirin is another famous acidic drug. It tends to bind to same acidic binding site of albumin. However, the number of these acidic binding sites on albumin molecule are few. Thus, some molecules of aspirin will displace some molecules of warfarin from their binding sites to occupy their place. These displaced warfarin molecules will become free, and thus will induce more anticoagulant effect, up to inducing bleeding. To avoid this serious interaction, the warfarin dose should be readjusted, depending on the INR test. Aspirin metabolism occurs in the liver. Metabolism starts by a phase 1 reaction, which is hydrolysis. Acetyl salicylic acid is hydrolyzed to release the salicylate ion. Then a phase 2 reaction follows, which is conjugation. The salicylates are conjugated with another moiety, e.g. glycine, glucuronic acid, etc. However, this step depends on the availability of the conjugated moiety. If it is not available, the reaction cannot proceed. This type of kinetics is called saturation kinetics. This means that at small to moderate doses, the conjugation reaction can go on, that is, aspirin follows first-order kinetics. At higher doses, above 4 grams per day, the conjugation reaction cannot accommodate the excess dose, that is, aspirin follows zero-order kinetics. Aspirin excretion occurs by glomerular filtration. This is the first part of the nephron, where filtration occurs. Any molecule, which is not bound to albumin, and whose size is less than that of renal pores, will be filtered. Aspirin satisfies these two prerequisites. 1. It is only 70% bound to albumin, that is, 30% of the dose is free. 2. Its molecular weight equals 180, that is, its size is too small. In the blood, aspirin is mainly in the ionized form, where the pH of the blood, 7.3, is well above the pKa of aspirin, 3.5. The ionized molecules will pass to urine, and they will stay in it, if they are kept in the hydrophilic state. The non-ionized molecules will also pass to urine, however, they will be reabsorbed back to the blood, since they are lipophilic. To keep the aspirin in the ionized hydrophilic state in urine, we should maintain the urinary pH well above the aspirin's pKa. Alkalization of urine can be achieved by sodium bicarbonate. Low-dose acetyl salicylic acid acts only as antithrombotic. Why? At very low dose, aspirin inhibits the platelet COX-1 enzyme, thus, it inhibits thromboxane synthesis. But still, why it does not inhibit other COX enzymes, at this very low dose? This is one of the endothelial cells, which line the blood vessels. They forms a smooth lining, to prevent friction between the vessel wall and the blood cells. And this is one of the platelets. However, it is not a true cell, since it lacks the nucleus. The cell membrane of both the platelets and the endothelial cells is made of phospholipids. The enzyme phospholipase A2 releases arachidonic acid from the phospholipids. COX enzyme converts arachidonic acid into intermediate prostaglandins. However, the type of COX enzyme is the endothelial cells is COX-2, while in the platelets it is COX-1. The platelets contain the enzyme thromboxane synthase, which converts the prostaglandin H2 into thromboxane. This is a potent platelet aggregator. On the other hand, the endothelial cells contain prostacyclin synthase, which converts the prostaglandin H2 into prostacyclin. This is a potent inhibitor of platelet aggregation. If you give low-dose aspirin, about 75 to 81 milligrams, it will be absorbed into the portal blood, where it meets the platelets, thus inhibiting its COX-1 enzyme. Then, they enter the liver, where they undergo first-pass metabolism. None of the low dose reaches the systemic circulation. Accordingly, other COX enzymes, whatever their type, escape from aspirin inhibition. Even if some aspirin escapes to the systemic circulation, the other body cells, unlike the platelets, are nucleated, and thus can synthesize a new COX enzyme. The platelet cannot recover from the inhibition, and new platelets should be released from the bone marrow, which takes 5 to 7 days. Moderate doses of acetyl salicylic acid, e.g. 300 mg 3 to 4 times daily, acts both as analgesic and antipyretic. At this level, aspirin inhibits COX enzyme, mainly COX-2 isozyme, to inhibit prostaglandin E2 synthesis. Prostaglandin E2 can increase the sensitivity of pain receptors to nociceptive stimuli. Pyrogens, which are responsible for hyperthermia, act through prostaglandin E2 to set the hypothalamic thermostat to a degree above 37. High doses of acetyl salicylic acid, e.g. 500 to 1000 mg 4 times daily, acts as anti-inflammatory. The 5 cardinal features of inflammation are redness, hotness, swelling, tenderness, and loss of function. All these features are secondary to vasodilatation. Aspirin, by inhibiting both prostaglandin E2 and prostacyclin synthesis, interferes with this vasodilatation. However, aspirin has nothing to do with the etiology of inflammation. Indications of aspirin may be classified according to the pharmacological actions. Since low-dose aspirin, 75 to 81 mg daily, has an antithrombotic action, it can be used in the following thrombotic diseases: transient ischemic attacks, which usually accompany cerebral atherosclerosis. Lifelong low-dose aspirin decreases the risk of its progression into stroke. Similarly, in angina pectoris, lifelong low-dose aspirin decreases the risk of its progression into myocardial infarction. Even in presence of myocardial infarction, low-dose aspirin is used to prevent a second infarction. EPH gestosis, previously known as preeclampsia, where the pregnant female presents with edema, proteinuria, and hypertension. In this case, there is a high risk for thrombosis in the placental blood vessels. The second group of indications is as analgesic, in mild to moderate painful conditions, e.g. headache, dental pain, pending visiting the dentist. In such case, avoid topical application, as this may lead to gum ulceration. Muscle pains as low back myalgic pains, accompanying veritable disc problems. Ligament pains, as in traumatic sprains. Pain on walking, or claudication pains, accompanying atherosclerosis. And lastly, spasmodic dysmenorrhea, which occurs in young girls before menstruation. However, aspirin is better avoided, and another drug as ibuprofen is used, due to its lower bleeding tendency. The third group of indications is the antipyretic group. Aspirin can be used in any fever as symptomatic treatment, irrespective of its etiology. The last group is the inflammatory group, where aspirin is used as a symptomatic treatment, in any disease accompanied with inflammation. The only exception, where aspirin is curative, is the rheumatic fever. If it is presented as arthritis, high-dose aspirin is enough. However, in presence of carditis, a more potent anti-inflammatory drug is used, usually a corticosteroid. One of the most common inflammatory conditions is the arthritis. Hence, these drugs as known as the antirheumatic drugs. Another inflammation is inflammation of the synovial membranes. Gastric adverse effects are the most common adverse effect of aspirin. They start with anorexia, especially if it is taken on empty stomach. Then, they may proceed to nausea and vomiting. The patient usually feels burning sensation, described as heartburn, because the cardiac opening of the stomach shares the same innervation as the heart. If more severe, gastric ulceration may occur, which is presented with vomiting of blood, hematmesis, or bleeding in the stools, melena. To guard against peptic ulceration, the drug should be taken after meals, a proton pump inhibitor may be added, and a non-steroidal anti-inflammatory drug, with less liability to induce ulceration, may be used, e.g. one of the coxibs. Taken the drug rectally, or parenterally, does not eliminate the risk. This is a figure showing the peptic ulcer. All non-steroidal anti-inflammatory drugs are absolutely contraindicated in presence of peptic ulceration, even the coxibs. The only allowed drug is acetaminophen. And this is hematmesis. Notice that the blood may be coffee-colored, due to the effect of gastric acid. And this is a bloody stool. If bleeding is more severe, the stools may be entirely black and soft, melena. Renal adverse effects are the most serious adverse effects of non-steroidal anti-inflammatory drugs. They vary from general adverse effects on water and electrolytes composition of the body fluids, to overt kidney diseases. The kidney contains both COX-1 and COX-2 enzymes. It can produce many types of prostaglandins. Prostaglandin receptors are distributed both in the vascular, tubular, and endocrinal components of the kidney. The most important types are the prostacyclin receptors in the afferent arterioles and in the juxtaglomerular apparatus, which secretes renin, and prostaglandin E receptors in the ascending loop of Henle and the collecting ducts. The prostacyclin can vasodilate the afferent arterioles, with subsequent increase in the renal blood flow and glomerular filtration. It also stimulates renin secretion, which activate the angiotensin pathway, with subsequent aldosterone secretion. Aldosterone leads to sodium retention and potassium excretion. Prostaglandin E2 Inhibits sodium reabsorption, in the ascending loop of Henle. And prostaglandin E1, interferes with the action of antidiuretic hormone, which controls water excretion. Since the nonsteroidal anti-inflammatory drugs inhibit prostaglandin formation, we expect that they will 1. Decrease renal blood flow and glomerular filtration rate. 2. Decrease potassium excretion. 3. Sodium retention in excess of water. Sodium and water retention is the first marker of renal affection. It may be due to decreased renal blood flow, secondary to inhibition of prostacyclin synthesis, with subsequent decrease in glomerular filtration. Or, secondary to enhancing sodium reabsorption in the ascending loop of Henle, due to inhibition of prostaglandin E2 synthesis. The retained sodium drags water with it by its osmotic power. The earliest presentation of salt and water retention is increased body weight, since each liter of fluid weighs 1 kilogram. However, this is easily missed. When the retained fluid volume exceeds 3 liters, edema starts to appear at the ankle, and creeps proximally as the retained fluid volume increases. The retained fluid can increase the blood volume, with subsequent induction of hypertension, in previously normotensive patients. If the patient is already hypertensive, his blood pressure increases more, and he loses control over his blood pressure. If the patient is on diuretic therapy, he may notice that the diuretics stop to increase the urine volume. If the patient has a cardiac problem, the heart may not tolerate the increase in the blood volume, and manifestations of heart failure occurs. Electrolyte disturbances can be detected in renal function tests. These may take the form of hyperkalemia. The hyperkalemia is related mainly to decreased renin secretion, with secondary decrease in aldosterone level, a famous hypokalemic hormone. It may be also secondary to sodium reabsorption. This decreases the amount of sodium delivered to the distal tubules. The distal tubules usually exchange this urinary sodium for blood potassium. Hyperkalemia may be serious, since the safe potassium range in the blood is narrow, between 3 and 5 milliequivalent per liter. Hyperkalemia can induce fatal cardiac arrhythmia, if the patient is receiving other drugs which increase the potassium level, example angiotensin converting enzyme inhibitor as captopril, potassium retaining diuretic as spironolactone, or is receiving potassium. It is also serious in presence of renal impairment. Hyponatremia is another abnormality, however, it is not that serious, since the safe blood sodium range is wide. Hyponatremia is not due to decrease in sodium, but rather, is due to increased water content of the blood. Water retention is secondary to inhibition of prostaglandin E1, which usually antagonizes the action of antidiuretic hormone. Acute renal failure is the decrease in urine output below 250 milliliters per day, which is not enough to get rid of body waste products. If this is the Bowman's capsule, which is the site of filtration, and this is the blood which is delivered to the capsule to be filtered. Prostacyclin dilates the afferent arteriole to increase the blood supply to the nephron. While angiotensin II constricts the efferent arteriole to limit the escape of the blood from the nephron. This forces the fluid to pass through the glomerular pores to the capsular lumen. Nonsteroidal anti-inflammatory drugs, by inhibiting prostacyclin synthesis, will decrease the glomerular filtration. This will decrease the urine volume, and decrease the elimination of waste products, as urea and creatinine. Usually this occurs within few days of start of therapy. However, it occurs only in subset of patients. For example, patients with low blood volume, hypovolemia, secondary to intensive diuresis, or dehydration. These are considered high-risk patients, and renal failure may occur even with the usual doses of nonsteroidal anti-inflammatory drugs. Receiving drugs which decrease angiotensin II, e.g. captopril, dilates the efferent arteriole, and subsequently, allows the blood to escape from filtration. Thus, angiotensin-converting enzyme inhibitors are additional risk factor. Cessation of therapy is usually enough to reverse the renal failure. Sometimes, 1 or 2 dialysis sessions may be needed. Acute interstitial nephritis and nephrotic syndrome are other forms of renal adverse effects. Both are related to increased leukotriene synthesis. This is arachidonic acid. And this is the cyclooxygenase pathway. And the alternative lipooxygenase pathway. Nonsteroidal anti-inflammatory drugs inhibit the cyclooxygenase pathway. Thus, shifts arachidonic acid metabolism to the lipooxygenase pathway, with subsequent increase in leukotriene synthesis. Leukotrienes increase peritubular capillary permeability, with secondary interstitial exudation. The patient may asymptomatic, or present with fever, blood in urine, and eosinophilia, up to renal failure. Leukotrienes also increase glomerular capillary permeability, with secondary escape of albumin to the glomerular filtrate. This occurs mainly in elderly women. And with the obsolete phenoprofen. Analgesic nephropathy is the most unique form of renal toxicity.